there was a little bit of uncertainty about whether this is a question-answer session or whether this is supposed to be a presentation of mine. So I think what I'm going to do is I'm going to make it interactive. We'll have a microphone go around for whoever wants to ask questions, and I'll do my best to answer them. So the lungs are sitting in our chest, and on this slide you see on the left a representation of how the organs all sit together, and there's the heart in the middle and the left lung and right lung, and right next to it you see a chest röntgenogram, and you've seen the chest röntgenogram probably a lot of times in the office with your doctor, and you wonder what these shadows are and how they relate, and you see that big white thing in the middle, that's your heart, and then you see the two dark things left to the heart and right to the heart, and those are your lungs, and they're dark because they're filled with air, so there's not much resistance to the X-ray to cause a shadow. So the X-ray is essentially a negative, so everything that's filled with air is dark and everything else is white. And if you have more white in the area where there should be dark, then you know that there is material there that doesn't belong into your lungs, and that's usually fluid, or it can be blood, or it can be granulomatous tissue. So that's why we always do X-rays to look at the lungs to see whether there's something there that doesn't belong there, that fills the airspace and prevents your oxygen traveling from the airspace into the bloodstream. Breathing symptoms in vasculitis are a very vast field, and we need to talk a little bit about the symptoms and what they mean before we can put them into a context that pertains directly to each individual patient. So when doctors talk about shortness of breath, they often use the term dyspnea, which is meaning the same thing, shortness of breath. But when patients say they're short of breath, we often have to ask, please describe what you actually mean by shortness of breath, because we want to make sure that we're not confusing it with fatigue or feeling run down and getting out of breath with very minimal movement, even though that can lead to shortness of breath. But there's often a gradient of what is meant. So actually having a conversation with your doctor of what is meant specifically by shortness of breath, finding out when you get short of breath. Do you get short of breath walking on a flat surface? Do you get short of breath when you run briskly? Do you get short of breath walking up a flight of stairs? Or are you feeling short of breath when you're sitting right in front of me? And all of these things have certain information in them, and in order to have a conversation and start an evaluation for why you're short of breath, we really need to be clear of what is meant. Now, other respiratory symptoms, either from the lungs or from the airways that connect our lungs to the exterior, can lead or cause cough, and cough is a common presentation of respiratory tract involvement in vasculitis, and we also like to understand what kind of cough you have. Are you coughing anything up? Are you bringing up phlegm? What does it look like? Is it yellow? Is it green? Is there blood in it? Or is the cough dry and not bringing anything up? Is the cough being triggered by certain things? Is it worse when you lie down? Is it worse when you're upright? And so on. So again, in the way you describe the cough to your doctor tells a lot of where the next things are that we want to look at. Coughing up blood is always an alarming sign. It's very alarming to you when you see it, and it should be very alarming to your physicians when they hear that you are bringing it up. But again, not all blood that you bring up is the same. Blood, a very little bit of blood, dime-sized blood, has a tendency to look very scary on a tissue, although it is rarely a manifestation of a massive bleed into the lungs. Very often, blood streaks in the sputum occur in the context of inflammation of the airways. Bronchitis is probably or upper respiratory tract infection or lower respiratory tract infection are probably the most common causes of having some blood in the lungs, even in patients who don't have anything to do with vasculitis. But whenever you cough up blood, we get concerned and we have to get to the bottom of why you're coughing up blood. And we need to make sure that we understand where it's coming from. Now, to complicate matters, when we talk about vasculitis affecting the lungs, there often is bleeding into the lungs, and the problem with bleeding into the lungs, we call that diffuse alveolar hemorrhage. Half of the patients who have their lungs filling up with blood from diffuse alveolar hemorrhage actually don't cough up any blood. So if we're concerned that there might be blood in the lungs, we very often have to take a look into your lungs with a bronchoscope, going down there and seeing whether we can get any blood back. And usually we can then tell whether the shadow that we see on your chest x-ray is due to blood filling the airways or whether it's due to a pneumonia. So then in the context of vasculitis patients, we often talk about wheezing. And wheezing is really a symptom of asthma. And asthma, of course, is most common in patients with EGPA, formerly Church-Strauss. Now, not everything that patients think is wheezing, or even some doctors think is wheezing, is actually true wheezing in the context of asthma. Because the wheezing of asthma, you cannot hear. And patients or people around you don't hear your wheezing. They just see you being short of breath. The wheezing that you're doing when you have an asthma attack is really something we hear with a stethoscope over your lungs. Now, very often, the noise that is being made when the large airway is obstructed, that makes a noise that sounds like a whistle or like you're breathing through a straw. And that type of noise, it really shouldn't be called wheezing, but we call it stridor. And that is associated most commonly with subglottic stenosis, but it can also be caused by fixed airway narrowing further down below in your airways caused by GPA or so. So we always have to make sure that we know what we're talking about before we get to the next steps. So when you're short of breath as a patient with vasculitis, it can have many causes. The shortness of breath can be caused by the active disease, and that is the most common cause of shortness of breath at the time when you're newly diagnosed. But after you've been diagnosed and have been started on treatment, when you're either still feeling short of breath or getting more short of breath, or later on have the beginning of shortness of breath, we also have to think of many other things of why you could be short of breath. And one of the major reasons to be short of breath is a complication of the disease, so damage from the disease or scarring that is left behind in your airways after the inflammation has been adequately treated with the immunosuppressive drugs. There are also treatment complications that can make you short of breath. Any pneumonia will make you short of breath. Any lung infection will make you short of breath. And since we're suppressing your immune system with the drugs that we use to control the disease activity, we're setting you up for infections. That's a reality, and we're very careful to not overdo it. We're always having this balance between treating the immune system enough, but not too much, so that you're getting into trouble with infections. And we give you prevention for certain infections, because infections can occur as treatment complications, and they in turn can make you short of breath. Now, there are also other problems that can lead to shortness of breath, directly or indirectly. One such thing is if you have obstructive sleep apnea, and many patients have obstructive sleep apnea, whether they have vasculitis or not. But in the context of vasculitis and steroid treatment, we very often see the development of obstructive sleep apnea. And if obstructive sleep apnea is not treated properly, you're very fatigued. But that's the symptom that you feel. But the obstructive sleep apnea does other things. It drives up the blood pressure in your pulmonary circulation. It's a reflex of low oxygen levels at night, leading to the vessels narrowing as a reflex. And then the right heart has to work much harder to get the blood through the lungs over onto the left side. And when that persists, you develop what is called pulmonary hypertension. And once that is fixed to a certain degree, that can also lead to shortness of breath. So when we see patients with fatigue and shortness of breath, we very quickly look for pulmonary hypertension as well as obstructive sleep apnea, because that we can address. So just in a nutshell, there's various different reasons for feeling short of breath, and when you want to find out why you're short of breath, we have to work through this in an organized fashion. So, in addition to this, the source of your shortness of breath is not always in your lungs or in your airways. That would be too easy. There are many things that can make you short of breath in the context of vasculitis. So we need blood to transport the oxygen to the tissues. And really, shortness of breath is caused by the fact that the oxygen requirements of your tissues are not living up to the demand by the tissues. So if for whatever reason you can't get enough oxygen to your tissue where it's needed, you feel short of breath. And there are many components in this that can cause this. So blood being one. So if you're profoundly anemic, then you're more short of breath. And if we can identify the cause of your anemia and bring it up to a normal level, you will feel less short of breath. You can have heart failure. When we have heart failure, there is fluid backfill into the lungs, and then the air exchange doesn't work, and we feel short of breath, not because there's anything wrong with the lungs, but it's because the heart is not pumping properly. We already talked about narrowing of the airways. If you're breathing through a straw and cannot breathe in any other way, you're going to get short of breath, of course. Lung tissue, we talked about. Anything that gives us a shadow on the X-ray will lead to shortness of breath. Pulmonary vessels, pulmonary hypertension, we talked about in the context of obstructive sleep apnea. But many patients with active vasculitis also have blood clots in their legs. We're very in tune with that possibility. During the time of active disease, patients are prone to develop blood clots in the legs, and these can travel to the lung. We call that a pulmonary embolism, and they can block the vessels in the lung, and again, that leads to high blood pressure in the pulmonary circulation. And who would have thought that the kidneys can be a cause of shortness of breath? Well, they can, and they can in two ways. One, if your kidneys can't handle fluid properly, you get fluid overloaded, and some of it ends up in the lungs and makes it hard to breathe. But also, the kidneys make a hormone that leads to normal hemoglobin levels. That hormone is called erythropoietin, and if you have chronic kidney failure, you may be on a replacement dose of that hormone, either in the form of Procrit or some erythropoietin supplements. Patients who are on dialysis usually get it when at the time of their dialysis, not every single time, but periodically. And the goal is to really bring the hemoglobin back closer to a normal level, because otherwise the hemoglobin will drift down further and further until you're really very anemic and very short of breath from anemia. So the kidneys also need to be looked at in the context of an evaluation for shortness of breath. And then last not least, and probably one of the most significant contributors to shortness of breath, is the fact that you've actually been ill and seriously ill for a long time. And when you're seriously ill for quite some time, you don't have the same activity levels that you used to have before you got ill, and as a result you lose a lot of muscle mass and you lose a lot of condition, and then when you start up moving again, everything is so much harder until you gradually build it back up. So all of these components need to be factored in when we evaluate you for shortness of breath or respiratory problems in the context of vasculitis. With that, I actually would like to close, but I'd like to, from now on, use the rest of the time to really answer your questions.
How much can your lungs regenerate themselves after you go into remission?
That really depends on how much damage there has been in the lungs. Fortunately, the lungs they are very resilient. So if you have a heavy bleed into your lungs, once the inflammation is controlled and the bleeding has stopped, the blood is cleared out fairly quickly and the lung function recovers fairly quickly. Now, if you have lung nodules, balls, or so round things in your lungs from granulomatous inflammation, that usually doesn't cause a whole lot of loss of lung function. So we don't pick it up on a lung function test generally. And when these lesions are there, they rarely cause you to be short of breath. And when they shrink away with treatment, you may not feel a whole lot of improvement. Now, the biggest problem with shortness of breath from disease activity and subsequent scarring is really what's occurring in the airways, particularly in the context of GPA. Because there can be narrowing at the time of active inflammation, or there can be no narrowing yet at the time of inflammation. And when these airway lesions heal with immunosuppressive therapy, they can do two things. They can either go back to their normal diameter and everything's good and you're not short of breath, or they can shrink down as a result of scarring, and then you have localized narrowing in various areas of your tracheobronchial tree. And then we usually need to go look at them with a bronchoscope, and if there is no more active inflammation, we can try to open these narrowed areas up, either with slipping in a little tube that has an inflatable balloon that we inflate that widens the airway back up. We call that a balloon dilatation. Or sometimes if there is narrowing from a scar that's kind of web-like and not very deep but very thin, we can open it up with a little laser cut and then widen it with a balloon. So it depends on the very specific situation in each individual patient that we see when we look into the airways with a bronchoscope, and then we make an individualized plan of what we can potentially do to restore the patency of the narrowed airway.
So in active disease, if there was blood in the lungs, and if there is a relapse again, would there necessarily again be the pulmonary hemorrhage, alveolar hemorrhage?
Yes, if there is alveolar hemorrhage at the original disease and you subsequently have a disease flare, can it recur in the lungs? Yes, it can recur, but it can also not recur, and the disease relapse can have other disease manifestations. So in general, when you look at large patient groups and you look for a theme, then you can say that the disease relapses that occur early after induction therapy have a tendency to behave similarly to the original disease manifestations. Now, if you've been, however, in remission, let's say for a decade, and many patients have been in long-lasting remissions, and the further out it goes, the more likely a subsequent relapse is to behave differently than the original disease. So in patients with PR3-ANCA who have a higher tendency to relapse, if you have a lot of relapses early, we watch out very carefully for anything that happened originally. And we certainly listen to you when you come to us and say, this feels like the disease is coming back. Because we know from studies that were done in the context of trials that patients feel the relapse usually about up to 3 months earlier before we can actually document the relapse objectively with lab tests or imaging studies. So, yeah. So I think we always have to work together in the relapse prevention, and patients are often their own best biomarkers. That doesn't mean that everything that you feel is necessarily a relapse, but one has to have a very thorough conversation and exclude other possibilities for the symptoms before we draw the conclusion that this is a relapse. So, yeah, we'll have to work together to prevent relapses going forward.
I have classic EGPA, really bad asthma for 10 years. I was not diagnosed. Then I bled in my lungs, you know, with the infiltrates. But then I started to get pleural effusions, and I never hear about pleural effusions with EGPA.
Yeah. Actually, so the question is pleural effusions in the context of EGPA, and that is actually not uncommon. About 10–15% of patients with EGPA can have pleural effusions, and similarly fluid in the sac surrounding the lung, the heart, we call that pericarditis or pericardial effusions. And when we stick a needle either into your pleural space to suck out the fluid and look at it under the microscope and test it in the lab, we usually see what's called an exudate, meaning there's a lot of protein in there, and that's usually associated with inflammation, in contrast to not having a lot of protein in there when the fluid is caused by heart failure. And then we usually, in the context of EGPA, see the eosinophils being the main cells in the fluid. So that's an eosinophilic pleural effusion, and that is generally a sign of disease activity and requires more immunosuppression, I'm afraid, to get it back under control.
All right, here's my little second thing. Very allergic as well, and I had a bee sting, and I took stuff for, you know, prednisone for the pack beyond what I took, and then I went into the hospital with asthma for 2 weeks. Have you ever heard of that, of like an allergic and then suddenly going into asthma?
Well, so EGPA
MSA.
is, of course, a condition that occurs in a background of allergies and atopy, as we refer to it often, and that goes hand in hand with asthma. And so if you have a bee sting, and that inflammatory stimulus that comes with it can certainly kick up an allergic reaction, and this allergic reaction can manifest itself as an asthma exacerbation. It can also lead to an anaphylactic reaction. So if you're actually allergic to bee stings, you probably should work with an allergist to make sure that there isn't, you're not set up for having an anaphylactic reaction with the next bee sting. You know, you might want to have an EpiPen with you in case you get another bee sting. Yeah, so but in general, patients with EGPA probably should also work with an allergist to know what they're allergic to, so that they don't get into a potentially life-threatening situation from a bad allergic reaction on top of everything else that's going on. Yeah. Question in the back?
Can you explain I think it's pronounced interstitial lung disease?
Yes.
And also, can Rituxan cause any kind of lung damage or heart damage?
So two questions. Interstitial lung disease in vasculitis. Now, that is a topic that I usually devote a 30-minute presentation to, okay? So let me try to make it simple. There is a recently recognized association between interstitial lung disease and microscopic polyangiitis. So interstitial lung disease means an inflammation in the tissue of the lung that is responsible for the gas exchange from the airspace into the bloodstream. And if there is scarring or inflammation in that interstitial space, then you get short of breath because the interstitium swells up, scar tissue gets deposited, and then the gas exchange no longer works properly and patients get short of breath from it. And there are a couple of various different forms of interstitial lung disease. There's one particularly bad one that we refer to as idiopathic pulmonary fibrosis, which if it occurs in isolation is called idiopathic, but the same interstitial lung disease can occur in the context of other connective tissue disorders such as rheumatoid arthritis, scleroderma, and recently we've also seen that patients can have ANCA if they have this type of interstitial lung disease. Now, in many patients, it's just the interstitial lung disease, no vasculitis, and a positive MPO ANCA. And I'm saying no vasculitis yet, because 25% of these patients with lung fibrosis and a positive MPO ANCA do develop other signs and symptoms of microscopic polyangiitis down the road. And when we see an interstitial lung disease with only scarring and a positive ANCA, we really tell the patient about the potential symptoms of microscopic polyangiitis so that they recognize them and come back to the doctor. And we also have them monitor their urine for microscopic blood with test strips so that we do not miss the first sign of inflammation of the kidney or glomerulonephritis, because that can come on without too many symptoms, and that's the time when we need to treat with immunosuppressive drugs. So I think of these conditions as not necessarily directly related. I think of them as comorbidities in a similar fashion as we very often see patients with thyroid disease or hypothyroidism developing vasculitis down the road. The frequency of thyroid disease is much, much higher in patients who develop a vasculitis than in the general population. So there may be an association, but it may not be directly causality. And we want to make sure that we have options to treat the vasculitis when the vasculitis treatment is needed, and treat the lung fibrosis with antifibrotic agents when the lung fibrosis requires it. Because what's happening in the lungs, the interstitial lung disease behaves like the same interstitial lung disease, either idiopathically or in the context of other conditions. So I think they're a little bit separated. That address your question? Oh, second part, yeah, rituximab. Rituximab generally doesn't cause any problems in the lungs. I've given a lot of rituximab over the last 20 years, and I've not really seen any serious pulmonary complications with it. It can, on very rare occasions, cause a cardiomyopathy or be associated with at least temporary heart failure. I've seen that on one occasion, and we've actually written this up with our colleagues in nephrology, and there are some other case reports here or there about that, but it's an extremely rare occurrence. Now, most of the problems occurring in the lungs in patients on rituximab are really the consequence of the suppression of the immune system. So there are infections that are related to the suppression of the immune system, and they can come in a variety of forms. Viral infections can occur, but again, surprisingly rarely. So most patients who are only on rituximab and on nothing else usually don't get bad infections unless they are hypogamma-globulonemic. So we need to keep an eye on the gamma globulin levels, and if they drop, then patients may be at risk for infection. And always be on a single-strength Bactrim to prevent pneumocystis pneumonia. Pneumocystis is a fungal pneumonia that is very rare, but when it occurs, it still has a 50% mortality associated with it. So it's very serious, and we like to prevent it as best as we can. So as pulmonologists, we always advocate to be on pneumocystis prophylaxis. And we have to be on this for as long as the B cells are depleted. And you should also be on it if you're on any dose of prednisone in excess of 15 milligrams and on other immunosuppressive drugs. So 15, yeah. But if your background rituximab, even if you come off the prednisone below 15, you still need to be on pneumocystis prophylaxis. I've seen it many times that the doctors say, oh, the prednisone is now down, you don't need it anymore. Well, you're still B-cell depleted for the next 9 to 12 months. So for the next 9 to 12 months, you're still at risk for pneumocystis pneumonia.
So I'm newly diagnosed and I do not have a pulmonologist yet. I was wondering when to be worried about your cough, because I have a nasty one right now. So I was wondering when to see a pulmonologist and how to tell them like what to look for if they're not entirely familiar with GPA.
Well, if you have a cough and you have GPA, you should see a pulmonologist, and ideally one who has a little bit of experience with GPA. Cough, of course, is again very common, and cough can have quite a number of causes. And when we have somebody without vasculitis come for a cough evaluation, we first look for all the possible triggers. So postnasal drip is probably the most frequent trigger of cough. Gastroesophageal reflux can be a very common trigger of cough, and then chronic cough, that is. But in the context of patients with vasculitis, we really want to make sure that there is nothing wrong in the lung tissue, and we check this by the appropriate chest imaging, starting with a chest x-ray, but maybe even going to a CT scan in someone who has real respiratory symptoms, including cough. And then we have to be concerned about the airways. And my threshold to take a quick look into the airways in a patient with GPA is very low, because you may have endobronchial involvement of your GPA that has eluded detection to this point, because you don't necessarily see it on an X-ray. So it brings us back to all patients with vasculitis really should have a multidisciplinary approach and have a multidisciplinary team with specialists from every affected organ being part of the team. And then you need a quarterback, and the quarterback usually should be someone who has experience with the disease, and this can be a rheumatologist, this can be a nephrologist if the primary involvement was renal involvement, can be a pulmonologist if the pulmonologist has some experience with the disease.
Left lower lobe, back, scarring, cleared up, and turned into asthma diagnosis. Never had asthma before. What caused that?
Oh, that's a difficult question. I would first of all make sure that the diagnosis of asthma is correct. And then if you hear localized wheezing with a stethoscope over the left lower lobe and nowhere else, then I would highly doubt the diagnosis of asthma and suspect that in the context of healing, there has been scarring in the airway and you have a narrowing, a focal narrowing of one of the airways leading to the left lower lobe. And the way to find that out would be to take a look down there with a bronchoscope.
MPA? That's what
Can occur in MPA, yes, too.
Okay.
they have ridden in on the same horse, or can bronchiectasis
Yeah.
be autoimmune in nature?
Yeah, good question. Bronchiectasis and MPA. And to tell you the truth, we haven't quite figured it out yet, but there is an association. Some patients with MPO-ANCA positive MPA have bronchiectasis, and we then often don't know what came first. Was the bronchiectasis already there? And did the infection or the colonization of these abnormally widened airways that we call bronchiectasis, did that colonization with bugs stir up the immune system to the point that the patient's immune system develops ANCA and then even further develops ANCA-associated vasculitis? I think we very often think about this connection of infections or chronic colonization with bugs in the patient with the right genetic predisposition to develop autoimmune disease, ultimately leading to the breakout of the vasculitis. And in that context, we can really reconcile this observation that some patients with bronchiectasis do develop microscopic polyangiitis. And there is one, I mean, we know that ANCA are being formed in the context of infections, but in most acute infections, ANCA goes away once the infection is fought off and never come back. And in the context of bronchiectasis, particularly if it gets colonized with a specific bug that's called Pseudomonas, we find ANCA that light up by immunofluorescence, but are not directed against the typical antigens like MPO or PR3. So there are non-specific antibodies that are being formed against bugs that we can probably detect. And if they happen to be the ones that are connected with the pathogenesis of vasculitis, then the patients may develop the vasculitis. So there, in that sense, there is a connection, but whether that's exactly the way it played out in you, I don't know.
I've got two tiny questions. One is, recently diagnosed, my wife, she was hospitalized, had a biopsy of the lungs at 10 different spots, and it was definitely GPA, but there was no granules. Is that normal? Does that mean anything? Could it be something else?
Okay, well, so that's a very specific question that I probably cannot answer without knowing what the chest X-ray looked like, what other organ manifestations and symptoms there were, what the ANCA type was, and
sinus involvement, lungs were completely
and what the
whited
actual
out. Yeah.
pathology reading was. So it's hard to say.
I'm asking, could it be significant? Or I mean, it was definitely GPA. The sinuses were involved.
I'd be happy to talk some more about that issue with you right afterwards. Okay.
My second question is if the lung deterioration occurs very rapidly, does that mean anything? As in, X-rays are clear, and 8 weeks later they're almost on a ventilator. Is there any? What I've never heard in any of these discussions is whether the differences in the progression of the disease has any significance or can be interpreted anyway, or whether it will pose a problem in a relapse, like it could happen so quickly that we may not act in time.
So you may remember the beautiful slide of the crash and burn and the frog from yesterday's presentation.
Right.
And you can say that the disease manifestations of necrotizing granulomatous inflammation and GPA are most often more of the frog type, slowly developing and not going downhill rapidly very quickly, but that has the problem associated with it that those patients are more likely to relapse. Now, the crash and burn is more what we see in patients with diffuse alveolar hemorrhage or rapidly progressive glomerulonephritis, and that can occur in both microscopic polyangiitis and GPA, these crash and burn situations. And they, if recognized quickly, are very amenable to definitive immunosuppressive therapy. And then they can go back to normal relatively quickly in most instances if we get to the patient before a substantial amount of renal function is lost irreversibly. So time is of the essence when it gets into one of those crash and burn situations. But then the chance of reversibility is also much, much higher. So does it say that the next relapse will behave in the same way? Goes back to my earlier answer. The sooner the relapse comes after the original presentation, the more likely it is to behave in a similar fashion. The longer out you go, the more likely it is that the relapse behaves differently.
Does the fact that a person has any form, any of the many forms of our disease, whatever you want to call it, does that tend to weaken the body or affect the immune system so that we're more susceptible to other foreign agents, diseases?
Yes, so the question, if I may paraphrase it, is does the disease set you up for more problems in other forms? And the simple answer is yes, and it does so in different ways. Number one is the disease in and of itself makes your body and your organs weaker and more susceptible to subsequent problems. Secondly, the treatment that we give you to calm the disease activity down sets you up for more infection risk down the road. So that's one side of that equation. The other thing is we know that unfortunately patients who have developed one autoimmune disease are more likely to develop another autoimmune disease. So there is an increased frequency. Similarly, the statistics tell us that patients who have a relative, first-degree relative with an autoimmune disease are more likely to develop an autoimmune disease. But it's no direct inheritance, and the development risk of an autoimmune disease in a first-degree relative is still relatively small, but statistically significantly higher than in people who never had an autoimmune disease. So there is a background setup of your immune system to get into trouble, and that doesn't get better, unfortunately. At this point, we can't give you a new immune system yet.
Let's talk about environmental issues. Who would I see? Would I go to my pulmonologist, or would I go first and then be referred, or what?
Well, we really don't know much about environmental issues because their epidemiological studies that we've had so far have really not come up with any very clear environmental association or triggers. Now, the only one that has given us a signal here or there, and again, it's a statistical signal, is silica exposure in the context of microscopic polyangiitis. So amongst microscopic polyangiitis patients, there is a slightly higher frequency of silica exposure than in the general population, and the other way around. Patients involved or people involved or exposed to silica have a slightly higher risk for microscopic polyangiitis than the general population. But it is a very weak statistical signal because the overwhelming majority of patients with MPA have not had silica exposure, and the other way around, the overwhelming proportion of patients with silica exposure or people with silica exposure do not develop vasculitis. So a statistical association doesn't necessarily mean causality. Now, that said, how can we reconcile this? Well, in the context of our understanding of the pathogenesis, meaning we have inflammation and an inflammatory trigger that ultimately leads to kick loose the stones that turn into, when they roll downhill, the vasculitis, so to speak. So we have the background of the immune system being abnormal, waiting for something to kickstart the overreaction. And in most instances, we seem to be able to trace it back to an infection. Most people will say, oh, I came down with the flu, or I had this respiratory tract infection, and after a while it didn't go away, or it came back, and then all of a sudden everything else started. That's the most common association, where we think infection is the environmental trigger that ultimately kickstarts the disease process. And if it wasn't that infection, it might have been the next infection. And silica exposure has a tendency to induce an inflammatory reaction in the lung that ultimately leads to scarring in the lung, and that's referred to as silicosis. It's actually also has some granulomas in there. So silica does trigger an inflammatory response, and it is possible that that inflammatory response, even if it is very low grade, kickstarts the vasculitis that is just there waiting to happen in a patient who's predisposed to develop an autoimmune disease.
Female telephone installer, 20-year-old, me, crawling in attics, under houses, pink insulation, possibility?
Well, I can't say yes or no with any degree of conviction, unfortunately. So, all right, I think we could take one more question. We're, I think, already a few minutes over time, and so one more question, and then I'll be happy to entertain questions in the back.
So we've had several speakers, including you, have mentioned the problems with silica, but it's always been silica that you're breathing. What about silica that's in food?
I'm not aware of any data about that.